So since everybody anybody that's here is already in Medicare, I won't go into the issues of your eligibility. I'm assuming also all of you guys that are here are fully into Medicare, the Part A and the Part B. Am I doing that correctly? Okay. All right, so you're all in Part A and Part B. And I presume you also have all your private insurance products. Am I correct in that presumption? You can say no. You can say anything. All right, let's do it in reverse. Help me out. What product do you have under the Medicare system right now? Okay. Is that better? So, can you guys hear me okay? All right. So, question I pose to you is, in fact, let me even, so we make it a little bit more intimate. Would you like to give me your first name?
My name's Marion.
Hi, Marion. And the guy next to you is? Richard. So, Marion, you're in Medicare, A and B. Okay. And what private insurance product do you have along with Medicare, Part A and Part B? Okay.
I fortunately have not used much of it.
Okay.
It's under the Blue Cross system. It's not the
Okay. Is it a product you had to purchase on your own, or is it something you had available because of your employment? Okay. All right. So what you chose to do is enroll in Medicare, and instead of using Medicare directly, Part A and Part B, as your primary coverage, you chose, either intentionally or unintentionally, to turn down utilizing Medicare directly, Part A and Part B. You chose instead to enroll in an HMO or PPO product offered by a private insurance company. They're referred to collectively as Medicare Advantage plans. And that's the fork in the road that every American facing Medicare has to make a decision on. And to give you an idea, move over. To give you an idea of that optional direction, take a look at page 5 of the handout. Pretty much everything I'm going to talk about for the next 15 minutes or so has to do with that. When an American is eligible and chooses to go into Medicare, they're faced with this big fork in the road at the very beginning of their entry into Medicare. Either they rely on Medicare Part A and Part B as their primary coverage, and they back it up with a supplement, a private insurance supplement purchased from companies like Highmark or Aetna or Cigna. Pretty much any company you can think of, you're likely going to be able to buy a supplement from them. They are typically referred to as Medigaps. Now, they might be referred to as purely supplements if instead an employer is saying, here, I'll get it for you. But for the individual that has to go into the market and buy it themselves, what they're purchasing is referred to now currently as a Medigap. Had you chosen that option, this is what it would look like for you. You would have the right for the rest of your life to go to any doctor or hospital anywhere in America. You would say to that doctor or hospital, my coverage is Medicare itself, Part A and Part B. Doctor, do you accept Medicare assignments? Now, I promise you, every hospital in America that's credited is going to say, yes, of course, we take Medicare. And about 90% of every doctor in America is going to say, yes, I work with Medicare. I take their assignments. If they take Medicare as an assignment, then they will accept your card. And accepting that card means they must also, by law, accept whatever supplement, whatever Medigap you also have. You have now expanded your capacity to go anywhere in America, anytime, to access your health care. There's no network of Highmark, UPMC, or otherwise There's no limitation in that capacity. The second characteristic, you can purchase a Medigap if you're entering Medicare at a typical age, 65 or thereabouts, not much older than that. And some guys are postponing it later and later because they work well past 65. But the normal presumption is I'm going to enter Medicare when I turn 65. I've got my A and B. And if I select, under option 1, a supplement, a Medigap, to cover the costs that Medicare A and B do not cover, and I select a good one for around $140, $150 a month, the entire cost of my in or outpatient care is fully covered, entirely, totally, forever. That's how good it can be. So for the cost of about $100.50, plus obviously the cost of being enrolled in Medicare itself, Part A and Part B, you now have what is about as close to perfect coverage as you can get. You can go wherever you want, and you have the expectation of knowing that whatever those services are you get in a hospital or outpatient is fully paid for by Medicare, Part A and Part B, depending on which type of service you're getting, an inpatient or an outpatient service. And the balance of the cost that Medicare is not picking up under A and B, the Medigap will pick up. And once you have that, it cannot be taken from you. It cannot be altered from year to year. It cannot be changed unless you don't want it anymore or unless you give it up. There's a fourth component that you would pick up, and that would be your Part D coverage. And that's typically somewhere in the teens or 20s, maybe a bit more. But the typical Medicare Part D, standalone, separate from attached to an HMO or PPO Advantage plan, they usually cost around 20-ish bucks. So in other words, for the cost of about $160, $170, in addition to what you pay to be in Medicare, you're getting about as close to perfect coverage as you can imagine. And that coverage stays in effect for as long as you want to pay the premium, theoretically for the rest of your life. What you chose is the alternative. The alternative is option 2. And what it works with is what you're used to, an HMO product or a PPO product, sold again by private insurance companies. These HMO or PPO products, commonly called Advantage plans, replace your reliance on Medicare as your primary coverage. Part A and Part B you still have. You must have it to be able to have a Medicare Advantage plan. But you don't get to use Part A and Part B of Medicare as long as you have your Advantage plan. Think of it as club membership, and that's about it. You put it in a drawer, shut the drawer, and when you go to a doctor or hospital and they ask, what is your coverage? You show them your Security Blue, or Freedom Blue, or UPMC for Life, or Aetna Silver, or whatever that Advantage plan's name is. With that comes a different set of characteristics. First of all, you're going to be probably paying less than the 150-ish, less than the cost of a Medigap. Maybe a lot, well, that's all relative. Maybe you're going to be paying zero premium or $20 or $30 or $40, or maybe you're paying more, which is ironic because for $80, which is typically what people, when they go in for an HMO or PPO, are thinking in terms of paying, for a few dollars more, not really a whole lot more, they could have a whole lot more coverage. But typically, they're enticed by the lower premium, or they're enticed by the value added to these products, such as the ability to be guaranteed access to a health club, the ability to get some basic dental or basic eye care, the ability to do certain things that are outside the realm of Medicare itself, but within the Advantage plans have the capacity to incorporate that. And so as a result, they're enticed by that. They're enticed by the efficiency of all of this being combined into one package. Their Part D is attached to their Advantage plan. Their dental, their eye care, it's all attached to their Advantage plan. As a result, these individuals are enticed with the reduction of premium, enticed with the package benefits, and as a result, because they're not worried, at least now, about the less coverage, the increased cost sharing of deductibles and copayments, they don't see that as inherently a problem. Later down the road, as their health deteriorates, as they start to worry, oh my, how much is this going to cost for my cancer treatment? How much is this going to cost for my heart surgery? How much is this going to cost for all my diagnostics? And they start to realize that the savings they may have encountered by getting a cheaper HMO or PPO than the option 1 package is reducing their ability to expect a more comprehensive level of coverage. And in addition, they're also limited to the doctors and healthcare providers in that network. Now, individuals will say in either case, it's okay. Whatever doctors are in the network are okay with me. Or they're going to say, you know what, I'll run the risk. The savings of not having to pay $150, $160, $170 with my Medigap product and my standalone Part D, the savings of that more than offsets the risk that eventually one of these days, I'm going to be faced with a more significant cost by my deductibles and copayments with my Advantage plan. And that's all right, as long as you understood these two options. What often happens, though, is individuals, when faced with the choice they're going to make, are not presented with both choices at all. They're presented with an HMO, PPO, some kind of Advantage plan. Hey, that's what you're going to have. And because the guy selling it is compelled to see the value in selling you that, because he or she's going to make a lot more commission, and plus their company's going to make a lot more profit by selling the HMO or PPO to you. You say, well, wait a minute. If they're selling this for less premium, how do they make more profit? And this is the issue within the Medicare system that most people don't understand, nor do they understand the impact of this. Medicare as an institution, as the government saying, are we going to cover you or not, has made a choice a long time ago. They are trying to steer you in the direction of obtaining private insurance coverage, rather than relying primarily on the government's benefit of Medicare A and B to cover you. So much so that they are subsidizing the private insurance providers of HMOs and PPOs to the tune of $1,000 or more a month for enticing you away from relying on Medicare A and B and instead enrolling in their HMO or PPO product. And as a result of that lucrative subsidy that the government gives them, they're passing on that imperative to their sales force. They're passing on that imperative to the whole marketing process to say we can make much more money by encouraging people to pick up our HMO or PPO products. Now we get to control their utilization. They don't get to go down to Baltimore to the Johns Hopkins, or up to New York to Sloan Kettering, or over to Minnesota to the Mayo Clinic, or Cleveland for their heart conditions, or anywhere for anything. They stay within the realm that we dictate as this is your coverage area. Now, they may offer some courtesy down in Florida or over in Texas, and maybe they will and maybe they won't. But even if they're offering that, they're still dictating how you access, what you get, and what you're being provided with. You don't get to step out of a system and say, I'm going to go get another opinion from another guy who's not beholding to this private insurance company to pay them. I'm going to some place that is going to hopefully give me a more objective and unbiased opinion of the process and incorporate me in the service. At least that's what you're hoping. And with the ability to go wherever you want to go and not be restricted by a network, chances are that you have more flex, more reach in the capacity, or at least it gives you the opportunity, a chance. So one of the things that, one of my pet peeves, big pet peeve, is the fact that most individuals, when I sit down and talk with them as one-on-one, which is effectively what we're doing, or in large groups, and when I poll them to say, how many of you guys have Advantage plans? How many of you guys even knew there was such a thing as a Medigap? How many of you guys knew how it worked? The difference between the Medicare A and B and the Medigap or the Advantage plans. How many of you understood what the impact of that down the road would be? And how many of you understood that you had 6 months in your initial entry into Medicare to make this decision once and only? And after those 6 months are up, you will never, ever, 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 ever be guaranteed access to a Medigap again for the rest of your life, unless you're prepared to go through underwriting, or unless you have what's referred to as a triggering event, which likely isn't going to occur. So the sad thing for most people in Medicare, and it's not about, oh, this was a bad choice, this was a good. It was a choice you had. Most people don't even know they have the choice, nor do they know what the impact of those choices are. And what they don't realize is they have a very limited time when they're in Medicare to make that choice. And once they've abandoned this option after the first 6 months, they're likely going to be in some type of HMO or PPO product, some type of an Advantage plan product for the rest of their existence in the Medicare system, essentially for the rest of their life. The possibility of being covered, and I'm going to ask, don't take any pictures, please. Hander? No pictures. Thank you. So in this case, if this is something that you are new to Medicare, and I'm going to presume not, you still have within that period, in fact, one of the exceptions gives you a free look for a 12-month period. You have the right to look at that. If not, what your choice is not a bad choice as long as you understand the limitations of those parameters and the willingness of how you're going to use it. Now, what brings me out at this point of the year is for those people that do have Advantage plans, people that have HMOs and PPOs, that they get to reevaluate every year and decide whether they want to keep that particular Advantage plan or move to another Advantage plan. So those individuals in a period from October 15th to December 7th are going to evaluate what they have, decide whether it's covering them sufficiently, decide whether there is something better by examining the other products that are being offered and moving. Now, as you indicated, you haven't had to use it much, so you're not really familiar with it because maybe a visit to a doctor or two is all you do. At this point, the capacity of your product works fine. It's doing what it's supposed to. Later down the road, as you get older, as your health potentially deteriorates, and if you're lucky, it'll never deteriorate to the point you have to worry. The rest of your life, you'll stay relatively healthy, and the day you die is the day you finally realize, wow, my health's not as good as it is. And as a result, what you've got is perfectly fine, and the need to reevaluate it from year to year is irrelevant. The likely first time you're going to reevaluate this is when the doctor starts increasing your prescription medications. So it's not just that you're not utilizing doctors or hospitals or healthcare systems extensively. You're also not taking significant numbers of prescription meds, or what prescription meds you're taking are not brand names. They're generics. And so getting the drugs, if you're taking them, is limited to only a few dollars for a 30-day supply. The time that we find clients coming to us, once they've gotten through the initial enrollment, once they are now settled into their product decision, is when the shock to their economic system occurs by either a diagnosis of a pernicious, costly condition or procedure compels them to pay way more than they ever imagined, or that they've been prescribed medication now that is well beyond generic, and they're paying literally hundreds or thousands of dollars a month for those prescription meds. And we're then tasked with finding a coverage which addresses the cost of the drugs in a better way, helps them resolve getting this in a more effective way, and getting them enrolled as quickly as possible. And it may work, it may not work, but this is usually how we intersect. When some change, either in medical procedure or prescription medication, compels them to re-examine the thing they've got. The tendency strongly is once you've selected a product, a company, as long as it's working, as long as you're getting to see the doctors you want, as long as you're getting to go where you want to go, it's fine. I'm not going to worry about it. And especially if the premium is relatively low, less than $100 a month on top of what you pay to be in Medicare A and B. Then again, you're going to say the same thing. Well, it's working and it's not costing me much, so what's the worry? And there is no worry as long as it is working that way. As long as you're accessing your prescription drugs in a very affordable way, or you're not taking any of them and it's no big deal, or the procedures you're getting are simple. A doctor visit occasionally just to check up on your health, maybe a blood or urine specimen, maybe an x-ray, maybe when you have an infection going into an urgent care or your primary care's doctor's office to deal with it. Not much more than that. And you're finding that the cost that you're spending for these kind of procedures is in the total year less than $100. In that context, it works quite well, and you're quite happy with it. The thing that you're going to contemplate, maybe not this year, maybe not 5 years from now, maybe never, is the thing that is not costing me much? Is it allowing me to access where I want to go to get the services I want? And is it within an affordable range? And not just being in hospital, not just outpatient, but also the idea of purchasing those prescription medications. So the bottom slide on page 5 is the indication of the parameters when Medicare annual enrollment season commences and the parameters for it, October 15th to December 7th. That wasn't always October 15th to December 7th. For a while, the enrollment season went all the way to the end of the year, December 31st. So December 7th is a relatively recent. But here's something that's more recent, more expansive of what you can do in terms of your Medicare enrollment options. On the next page, for the past year now, 2019, and will continue into 2020, what most individuals don't know is once the initial enrollment period ends, December 7th, with the expectation that their Medicare products, their Medicare Advantage plan or their Part D plan will go into effect January 1st and stay in effect throughout the rest of the year, they also have, with the beginning of the new year, in January, in February, and in March, the capacity to reevaluate what they've just chosen. In January, February, March of the new year, they can decide whether they want to keep that Advantage plan or swap it for another Advantage plan or drop out of it completely and rely on Medicare Part A and Part B as their primary coverage, and if that's the case, also pick up a new standalone Part D plan. If they do that, whatever they've chosen during this extended period, this January, February, or March period, goes into effect the first day of the following month. So if you make a correction choice in January, it'll go into effect February 1st. If you make a correction choice in February, obviously March 1st, and so on. You get one choice during this period. One choice to swap your Advantage plan for another one choice to drop it altogether and rely on Medicare Part A and Part B and pick up a standalone Part D. Some things you cannot do at all is swap from a standalone Part D to another standalone Part D. What you can't be guaranteed doing is picking up Medigap. Again, if you're not in your first 6 months of being in Medicare, the best you can hope for is if you try to enroll in a Medigap product, option 1 of what we've been talking about, you're going to be underwritten by the insurance company. So after your first 6 months, you can still attempt to enroll in the Medigap product, but that enrollment will go through an underwriting scrutiny, and if you have health issues or they suspect you have health issues, based on about 20 or 30 questions they ask you, utilization of drugs, body mass index, a bunch of things, they're likely going to tell you, no thanks. We'd rather not do business with you because you're going to represent too big of a risk. And so often, because people tend to make their selections based on an Advantage plan initially and stay with it and don't even bother to worry about enrollment season. Or when they do, they make their decision in October and November and stick with it. This is a underutilized period, but it exists. So just tucked away in your back pocket in case. There's three other things that are going to go into effect for 2020. The first, honestly, for you guys is going to be irrelevant because whoever I'm talking to right now are all in Advantage plans. So to tell you that some of the Medigaps that exist, some of the levels of coverage under the Medigap system, under option 1, are going to be eliminated starting in 2020 is not going to have real impact on you. Right now, it's less likely you're going to get a Medigap at all. So to tell you, oh, when you finally do, you'll have a slightly reduced choice of products to get. But for some individuals, specifically individuals that want to get a Medigap when they enter Medicare, are planning on getting it, having those options reduced significantly. Two of the best product lines of Medigaps are being eliminated starting in 2020. There's people that are protected, they're grandfathered. These are people that have already purchased those levels of Medigap. They're entitled to hold on to them for an indefinite period of time, as long as they want it, and they're not going to be precluded simply because the Medigaps are being taken away. And individuals that have simply turned eligible for Medicare. They've already reached 65. And they simply haven't gone into Medicare. They postponed the entry into Medicare till a later time. They're going to still be guaranteed access to this high level of Medigap coverage, the F level or the C level, the two levels of products that are being eliminated. So I simply mentioned that. The one I'm going to emphasize, the one, let's say, that is, more imperative right now, and maybe not even. You guys are healthy, you guys are independent, you guys are not worried too much about health, let alone what's going to look like personal care issues. But for a lot of people in Medicare, this is going to be a big deal. Starting in 2018, on page 7. Starting in 2018, Medicare initiated an expansion of services that can be offered under Advantage plan products. It went into effect at the beginning of 2019, and it's continuing for 20, and more so, they've even expanded it further for 2020. Now, up until this point, essentially, the products that were incorporated under the Medicare Advantage umbrella were health-related. They were health services. They were access to doctors, access to hospitals, access to care, prescription meds, those kind of things you're used to at least knowing that you can have. What wasn't typically accessible using these HMO and PPO products was access to personal care services, access to things which would be defined not as medical, but as care-oriented for your personal needs. And I'll give you some examples, but let me say that the paradigm shift starting for 2019 was as long as they were perceived to be primarily health-related as opposed to specifically health services, they could be incorporated. And the kinds of things that were introduced in 2019 were things like accessing home-based healthcare services, accessing palliative care at home, accessing adult daycare programs, accessing entities that could provide home safety devices. Nothing elaborate, grab bars, slippy-slidey preventatives, and also the ability to access services that would help them get to their doctor's appointments, help them get to their medical services. One of the things that a lot of people face, especially older individuals that are less capable of being independent, people that are less capable of driving themselves here, there, everywhere, when they get really sick and they need to get to a doctor or a hospital, they tend to rely on an ambulance to get them there. They don't have friends, they don't have a support system, and they're having an event that they're not sure is serious or not, and they're worried that this could be a critical situation. They react by calling 911. 911 sends an ambulance out. They go to the hospital, the emergency room, and the emergency room says, okay, this is what it is. And even if it's relatively serious, once the individual is stabilized and sent home, thinking, okay, because they called 911 and because they sent an ambulance, because, it must be okay. They find out this was denied by their insurance. The insurance says, wait, this wasn't an emergency. Well, I thought it was an emergency. Well, we don't think it's an emergency. And when they deny that, they pass the entire cost of that ambulance onto the patient, which is in the tunes of hundreds, even thousands of dollars for that service. So grandma, who's having an event that she's not sure whether it's just gas or whether it's a heart attack, is panicked. She calls 911. They send over an EMT. They say, let's take you in. They pack up grandma in the ambulance, take her in, stabilize her. It was gas after all. Or yes, it's a heart condition, but it's okay. You're stable. We'll get you back as an outpatient later on to do some additional tests. They take her home. And a month later, she's presented with a $1,200 bill. Highmark says, sorry, not covering it. Wasn't an emergency after all. And she says, wait, I have to wait to see if I'm going to be dead first? Pretty much. It's like, wait a minute, I was not even conscious at the time. Doesn't matter. Are you kidding? No, we're deadly serious. The expansion of this prerogative for insurance companies to offer expanded benefits can also, but not guaranteedly, incorporate non-emergency transportation. So this widens the possibility that certain insurance companies can offset that possibility. The question is, are they going to do it? The question is, will they offer as part of their benefit package? Now, not just in case of emergency, we can get you to the hospital, to the emergency room, but generally, if you are traveling to see your doctor under normal circumstances, if you're traveling for a medical appointment under normal circumstances, and certainly if you have to go to the emergency room because you're worried, these are all incorporated under the circumstances. But individuals have to be particular in examining the product before they enroll for the upcoming year to see if in fact this is offered, and if it's offered, how it's offered. And most people do not think in those terms to even know to ask that question, because they assume when they see ambulance service covered, oh, I'm okay, not understanding it's ambulance service related only to emergencies, and it's the insurance company that very stringently dictates that definition. So it opens the possibility of this being an extension of that service, but there's no guarantee, and if this is a value, you have to be careful when you go shopping that this is part of it and what the parameters for accessing that are. In 2020, or for 2020, the Medicare system, Centers for Medicare and Medicaid Services, took these concepts one step further. Not only are there services now available that are primarily health related, these are services that are such that if there is utilization of these new benefits, it's with a reasonable expectation that it's going to improve or maintain the individual's existing health or their overall functionality. And the plans, if they choose to, get to customize this new benefit package to the particular patient individual. We're no longer just talking about the possibility of some in-home medical care or in-home palliative care or in-home support services or transportation to and from medical. We've opened this up significantly if insurance companies want to offer this. Such things as home-delivered meals to individuals, a service where not just delivering meals, but also going and do the grocery shopping. And I don't mean, oh, we'll deliver the meal and you owe us. No, this is part of the value. How much do I owe for the meal? Nothing. It's covered. Whoa, with your insurance. My groceries? Covered, taken care of. Don't worry. That's why you're paying your insurance premium. Wow. What else? How about home cleaning? Really? You're going to clean my house? Clean your house. Really? It's like, but why? Because remember, it's related to the idea that this service of delivering your food, getting your groceries, this service of cleaning your house or pest control or the quality of the air you're breathing in your house, all of these things are related to your health condition. And that by cleaning your house, by reducing the particulates in the air in your house, by helping you access better food or specific foods based on what your diet requires because you don't have the means to do it on your own, all of these things will have a reasonable expectation of improving your health and leading to better functionality. It goes even further. Under these coverage, you can have structural modifications to your home, not just some grab bars or some basic things to keep you from slipping and sliding, but significant changes to the home itself to allow you to better function within your home and remain in your home. Social support services that come not just for healthcare reasons, but to visit, keep an eye on you, make sure you're doing okay. And general living support. People that are provided by the insurance company to come to your home and sit down, go through your mail, take voicemail messages off, figure out how to make sure that you're navigating properly through your basic life requirements. Now, all of these things open up an incredible door to the possibility of what your Advantage plan can possibly do. The issue, though, is there is no mandate that these benefits must be in every Advantage plan. These are all optional. So we have the possibility now, as long as this stays in effect, and it's likely it is going to stay in effect because the philosophy behind this is if we can keep people healthier for a longer period at home, if we can keep them functioning at home independently with some support mechanisms, we keep them out of nursing homes, we keep them out of a in-home support service that requires literally thousands and thousands of dollars a month, or God forbid, they're in a nursing home which is going to be $6,000, $7,000, $8,000 a month. We're effectively saving, in the long run, the cost of this person's deterioration or the inability to care for themselves. So a minimal amount of effort in the upfront in terms of preventative deterioration can reap a significant reward in terms of the individual as well as the community. The problem is, although these are awesome and expansive services that are going to change the nature by which we look at HMOs and PPOs, there's no guarantee any insurance company is going to offer them, the degree they're going to offer them, the cost sharing they're going to impose. I painted a perfect picture where, don't worry about it, your groceries are fully covered. No, your groceries are only 10% covered, where's the other 90%? Or we only get you that, where's the rest? So this is going to require, for those individuals that see the value in this, a greater scrutinization of how that particular product is going to address those needs, the limitations, and the cost sharing required with it. As I said, we already talked about the elimination of the particular Medicaps. There is one other thing that's going to have a significant effect on a large number of individuals. Not you guys necessarily, because from what you're indicating, you're not taking any or a lot of expensive medications. But for those individuals that are taking significantly expensive medications or a significantly large number of medications, the biggest concern they have in the Medicare system is not whether they go to a hospital or a doctor, whether they get in-home personal care or support services. It's not whether they have a Medigap or an Advantage plan. It's regardless, it's how am I going to pay for my prescription medications? How am I going to be able to utilize Medicare effectively to get the drugs I'm supposed to take? Now, if all the drugs they're taking are generic, it's not going to be an issue. There's individuals that are going to be taking a half dozen or more generic drugs, and they're going to spend in any given month less than $20 for all of the drugs collectively. Many of them have a zero copayment. Many of them have no more than $2 or $3. So it's not unheard of that most individuals can afford, with basic, not very extensive coverage, the ability to access their prescription meds. For individuals who are not that lucky, they have to take prescription meds, and at least some of those meds are not generic. They're looking at a significantly higher cost that may preclude them from accessing those drugs. Now, under the current Part D format for 2020, the expectation is, and if you take a look at the last page, page 10, you get an idea of what a typical Part D plan looks like. A typical Part D plan at the beginning of the year may very likely have a deductible. For 2020, the deductible can be as much as $435. That's your cost requirement. If you have a plan that imposes that deductible, whether it's a few dollars or all the way up to over $400, before the plan, the private insurance company pays for the cost of your prescription medications, you must pay dollar for dollar the cost to eradicate that deductible. Most plans that have deductibles will only impose that deductible on non-generic drugs. So even with a plan that has a really robust deductible, hundreds of dollars, if all you're taking are generic drugs, it's not going to apply to you. You're still getting your generic drugs at $0, $1, $2, $3, $4. But if you're taking, again, any non-generics, you're likely going to pay dollar for dollar the retail cost of those drugs, which could be hundreds or thousands of dollars until you first paid off the deductible. Then, once the deductible is met, or if there's no deductible to begin with, the Part D coverage splits the cost of the prescription drugs, typically on a line of about 75% for the insurance, 25% for the beneficiary. It could be better. It could be an 80-20 split. It could be a 95-5. It could be that, especially for generic drugs, the plan covers the entire amount as a perk to get you to enroll in their product. Chances are, if the drugs are not generic, it's going to be much more aligned with the 75-25 split. That continues throughout the year, you paying 25% or some percentage for your drug, and the insurance company paying a much larger percentage for you to access your drugs, until you have spent between your money and the insurance company's money a certain amount. Now for 2020, that certain amount is $4,020. That is the threshold. That when you hit that amount, you're about to go into the coverage gap, also better known as the donut hole. In old days, when you were in the donut hole, you, the beneficiary, paid the entire cost of your prescription meds. You, the beneficiary, were required to cover that cost until you reached a point where you had bought your way out of the donut hole. And that's typically usually thousands of dollars more. So what puts you in the donut hole is what you and the insurance company spend on your drugs. Once you're in the donut hole, you, under the old paradigm, pay the entire cost of those drugs until you, out of your own pocket, spend enough money to get on the other side of the donut hole. And currently, for 2020, that's over $6,000 to buy your way out. After that, for the rest of that year, you're in what's called catastrophic coverage, whereby the the insurance company is on the hook to pay 95% typically, and you're going to pay 5% of the drugs. So you're going to pass through, most likely, 3 or 4 stages in any given calendar year, in any given plan year with that Part D. If there's a deductible, you may be paying off the deductible. Once the deductible is met, or there is no deductible to begin with, you're in a cost sharing with the insurance company, typically on a 75-25 or an 80-20 or better split, until you've spent between your money and their money enough that you're now no longer counting on the insurance company to kick in. And the burden would have been on you until you bought yourself out of the donut hole into the final phase, catastrophic coverage, or until the year ends and we start the cycle all over again. Here is what has been happening, though, over the past decade. Under the Affordable Care Act, Obamacare, a stipulation that addressed the needs of individuals in Medicare and their cost of prescription meds when they were in the donut hole, said, we will help you with the cost of your prescription meds once you go into the donut hole. Now, that has been increasingly getting better year after year. So from the inception of the introduction of the Affordable Care Act to just now, we've been looking at the help that individuals get when they're in the donut hole equal the cost splitting that they would have been subject to before they went into the donut hole, which is a 75-25 split. Now, this is an absolute. It isn't like, well, if your plan was giving you 90%, we'll cover. No, it's regardless of what the plan was splitting the cost of your drugs before you went into the donut hole. When you go into the donut hole, there is literally a 75-25 split. You, the beneficiary, are on the hook for 25% of the cost of that drug, whatever it is, whether it's generic or brand name. A combination of the manufacturer, supported by the federal government, and the insurance company is now going to split that 75% that you no longer have to pay. And this is what they mean by when they herald the donut hole's eliminated. Not it really. It still exists, but the support you're getting once you go into the donut hole via the federal government's program guarantees that the impact of being in the donut hole is mitigated significantly. You'll probably find that the difference between what you're paying for your drug before you go into the donut hole and what you're paying for it while you're in the donut hole is literally the same or negligibly different. When you're in the donut hole and you're getting support to pay for those drugs, some of that support goes towards digging you out of the donut hole, towards getting to that magic number on the other side of the hole, which puts you into catastrophic coverage, which brings the insurance company back online with a requirement of paying 95%. So it is a good thing. It's an important thing, especially for people taking high-end, expensive drugs that are faced with what would have been a decade ago or even just a few years ago, a cost sharing while they were in the donut hole that was insurmountable. But the thing that's so problematic with individuals is even before they go into the donut hole, when they're doing a 75-25 split, when they're in the donut hole, a 75-25 split, those costs could still generate if the drugs were very, very, very expensive. The requirement that they're still paying thousands of dollars in order to secure the drugs. And again, if you're healthy, if you're not taking any or only generic drugs, you're not going to see the issue. But once the healthcare system imposes on you the likelihood that to maintain some degree of health, to combat the condition that you've developed, you're going to have to start taking drugs that are significantly more expensive and maybe out of your reach. And so one of the things that we do when we sit down with a patient in the initial review of their health care is not just ask, how do you use your healthcare system? How many trips to the doctor? How many diagnostics? When was the last time you were in hospital? It's also, bring me a list of your prescription meds. Tell me what the meds you take are. Let me take a look at how that's going to cost. Again, if you're lucky, you're not taking any or a formulary of only generic, and your costs are going to be minimal, and the choice you make is not going to be that significant. But once we add on things like insulin and drugs to combat unique chronic and pernicious diseases, arthritis, COPD, and I could go on and on. When we look at chemo drugs that are combating life-threatening conditions, we're finding that the cost to secure those drugs on a continuous basis is more expensive than all of the other costs related to their health care. They exceed the premiums, they exceed the co-payments, they exceed the deductibles. And it's those individuals that are faced with the dilemma of, do I keep my house? Do I maintain any kind of existence that looks like what I had expected? Or am I at a point now where I'm simply spending most of my resources, most of the money I've accumulated that hopefully would be a legacy, to simply obtain the drugs that would necessarily keep me alive or at least maintain my health? And more every year, individuals are looking at that as the primary thing that concerns them the most about the choices they make with their Medicare coverage. It's not the Advantage plan. It's not whether to get a Medigap or not. It's what are my drugs going to cost me? What is the best solution? So one of the other things our program does is not just address which product is going to be best for the individual, but also whether there are other benefit programs that will help mitigate those costs, programs that will help pay for the cost sharing for healthcare services, pay for the prescription medications, or even just pay for the premiums related to being in Medicare, the Part B premium or the premiums related to their Advantage plans or their Medigaps. And one of the things that is essential when at least we're doing our counseling is to look at the individual's utilization of healthcare services, the kinds of services they're likely going to use, the drugs they're going to be taking, but also looking at their economic profile. What's their monthly income? What are their assets? That income and asset profile is going to give us an idea of whether that person is eligible for additional benefits that often they don't realize that they're eligible for. And as a result, those individuals are going to be able to access the costs of their services and the costs of their medications through these benefit programs in a much more effective way. So one of the things I'd hoped that we would do this evening is have a turnout of the throngs of people, and then we could talk about the services that we're going to be doing in the upcoming month of October and November, and entice people to come to our one-on-one counseling events that are going on the 17th of October at the Bethel Park Community Center, just across the railroad tracks. From essentially 1 o'clock to 4 o'clock. We'll be there a little bit earlier, but we seem to be having the core of people showing up between the 1 o'clock and the 4 o'clock time slot, which is fine. We have right now about a half dozen to a dozen people enrolled. We anticipate enrolling some other individuals. We're going to be throughout Allegheny County in October and November at least a dozen or so locations. In the north, south, east, and west of Allegheny County, sitting down with individuals in libraries, in church halls, in schools, in hospitals, in community centers, and reviewing their particular healthcare coverage, their particular healthcare needs, what they currently have if they are already enrolled in Medicare, and whether that's going to effectively work to continue their coverage. We're going to make recommendations, but not enroll them. Our program, which, for the record, is the Pennsylvania Healthcare Benefit Support Program, is a nonprofit affiliated with the Birmingham Free Clinic on the South Side, which provides these services at no cost. We are not brokers. We're not insurance salesmen. We're not insurance agents. I'm an attorney. Steve Lasky back there. Steve, stand up and say hello to all the millions of people looking. Yes. Is a physician. And we have, in addition, other lawyers, pharmacists, social workers, and these are the individuals that sit down with people like you and say, let me see your list of drugs, let me see your list of healthcare utilization, and let's see if what your current coverage looks like as far as giving a effective utilization. And it's good. You know, you get to go where you want, you see the doctors you want to see, the healthcare services you need to get, and it's affordable. That's called good, and hold on to it. If it's not working that well, if there's something that can be better, we're going to recommend. And it's up to you to decide whether you want to move on it or not. We are not compelled to make a sale. In fact, we couldn't sell if we wanted to. We don't hold brokering license, and we don't want to. One of the conditions of being part of our program is you cannot be an insurance broker. You cannot have an insurance license. Thus, there is no capacity for us to try to sway you towards one direction or another. It's non-economically productive, whatever you do. We're hoping that the goal is to educate you at making the right decision and compelling you to understand what your options are and act on those. Also to help individuals who have slipped through the cracks as far as not being aware that there are benefit programs that would help them access their prescription meds, that would help them access their health care at a more affordable price. And these are the kind of things we do. We do them certainly in October and November and early December during the Medicare's enrollment season, but we essentially do them throughout the year. Any given month of the year, people are going to be turning 65. People are going to be faced with, what am I going to do? How am I going to do it? People are going to be saying, look, my economics now preclude me from being able to access these care services. Is there something that can help me? We say, sure. We'll sit down with them and we'll help show them what their options are and navigate them through the process. This particular time of the year, we make an effort to get to the community. In the other months, January through September, basically you come to us. You come down to the Birmingham Clinic and sit down with our counselors there. But for the time being, we're going to bring it to you. And we're hoping that the community takes up this offer, a free service that will help you examine your current coverage and see if it's working as well as it can be, whether there's something better, and if there are other benefit programs that are out there that may help you access your healthcare services and prescription medications at the most affordable price. Are there any questions? Yes.
So, Bill, can you name some of these? I know you rattled off some of the conditions that make you have high drug, you're putting on a lot of money. So, I remember you said like insulin,
Well, diabetes.
COPD. What were some of the? Could it be like?
Well, actually, I happen to have a real expert here who can rattle them off more than I can. So come on up, Steve. Just, stop hiding.
Sue, of course, you know me, we've met before.
Now, don't walk and talk at the same time. It's dangerous.
I'm getting there.
And then when you get some microphone, turn it on a little back.
Okay, which mic do you want him to use?
One was, that's fine, as long as you have that little soft thing or something.
Okay. Yeah, get your little soft thing.
Keeps it from clicking. Yeah, there you go.
How's that? Can you hear me okay? So, there are two things to remember, Sue. I'll phrase it a little different way, but I'll give you an example. What Bill mentioned in a general sense, if a medication is a generic, meaning that although the doctor may prescribe something for a condition, let's say a diabetic drug, not insulin, an oral drug for diabetes, then most likely metformin, for example, there are many companies that have metformin. A drug to lower cholesterol, Lipitor, is a brand name, yet there are a variety of companies that have atorvastatin, which is the generic. So in Medicare terms, if drugs are generic, and if you have an Advantage plan, then there are, if you will, preferred generic, which would likely be therefore a tier 1. There might be a few that are tier 2, and your copays will be low. Again, if they're preferred by the Advantage plan. In like fashion, brand-specific drugs, specialty drugs for specific insulin. These wonderful, I'm not making a joke, they're very convenient. The insulin pens. If you remember, some time ago, there was a lot of publicity about one particular company that was making the EpiPen and how much that company wanted to charge. So, diabetes, insulin dependent. Patients who've had transplant, anti-rejection drugs. Again, these are specialty, brand-specific drugs.
Or which you're not going to find a generic alternative.
So there's not a generic alternative, as Bill just mentioned. And now, again, in Medicare terms, these are tier 3 or tier 4 or, oh my goodness, tier 5. So again, if you happen to watch television, what bothers me, number one, because of what the drug companies are receiving from the advertisements and some of the actors who even pose for these advertisements. But if you think of drugs like Xarelto or Eliquis, these are drugs that are used in certain conditions instead of Coumadin, which there is a generic for. And the Eliquis or Xarelto drug 1 year may be a preferred but brand-specific drug, higher tier, and the next year, I forgot your names, I apologize, but the next year they say, Steve, we no longer have that on our formulary.
Or it's on
Well-
your formulary, but it's not preferred.
Or it's not preferred, exactly. So either you have to discuss with your doctor, is there something else I can take? Or you make the decision to say, well, gee, I'm going to bite the bullet. I kid you not. I speak from personal experience from my 94-year-old mom. Or you say, well, okay, I guess I have to come up with the $400 and some copay monthly for that one drug. So, going back to your question specifically, we hit insulin-dependent diabetes, transplant, anti-rejection drugs, chemotherapy. Patients don't realize that, of course, there are wonderful drugs to hopefully control and put in remission certain conditions of cancer. Again, you don't plan to have cancer. You don't plan to have a stroke. You don't plan to have a heart attack. But again, if they're brand-specific, higher-tier drug, and whether it's a Plan D that you're on, meaning an independent drug plan, or your Advantage plan, from year to year, the formulary can change. It's not as if they notify the doctor first. They notify you, and you communicate with your physician. Does that help answer the question?
Oh, yeah. So
And then, so there are other,
one with the HMO or the PPO, if you have the Medigap or Part A and B, then you're not pigeonholed. You can have those more expensive medications.
no, either way, Sue, the difference is this. In the Medicare Advantage plan, the drug plan is built in. So again, if, I think you said Highmark, whichever the plan may be, so Highmark has a formulary for that particular plan. And again, within their formulary, they have set preferred generics, preferred brand, and specialty, especially now in their brand drugs, specialty, chemotherapy, insulin-dependent diabetes, things like the drug Humira, another wonder drug that's advertised a lot. Very expensive. Why? Because there's no generic equivalent. So 1 year, and I'm not either praising or maligning Highmark. 1 year, hypothetically, Highmark might say, okay, well, we prefer Xarelto. Yeah, but my doctor wrote for Eliquis, and this is the reason. Talk with us. There are many steps they can go through. It's not easy. You could ask your doctor for an appeal to Medicare, for a tier exception, and all sorts of special documentation required to see if the doctor would be able to then, or get the insurance company to make a case exception for you. And or there's something else called the Patient Manufactured Drug Assistance Program. So basically, the doctor helps certify that this particular medication is life-sustaining, that you've failed other therapies, that there's nothing else like it that can control your condition, and you can't afford the medication. And in some cases, then the manufacturer will basically ship the drug either to the physician for you or directly to you.
But an important takeaway is, if you're enrolled in a Medicare Advantage plan, an HMO or a PPO, and that Advantage plan has built into it Part D coverage, you cannot go shopping for an alternative because that particular Part D doesn't cover your drugs, or doesn't cover them all, or doesn't cover them very well. Whereas, if you went with the other option, I'm using a Medigap, which never incorporates Part D coverage, and that's actually a positive thing. That frees me up to go shopping independently for a better form of prescription drug coverage. Now again, if you're not taking any drugs or hardly any drugs, or none of them are very expensive, you're like, okay, so what? But when finally the doc says, you know what, you just crossed the threshold, it ain't gonna be metformin anymore, you're full-blown diabetic. Oh God. Yep, you're gonna have a lifelong relationship with insulin and all the other stuff that goes with it. Oh, I shouldn't have had that last chocolate sundae, should I? No, that was pretty much the thing that pushed you over. And as a result, now suddenly, you're looking every time, every year, it's like, am I going to be able to access my insulin? Am I going to be able to access those drugs related to that? Or change it from insulin to COPD, or change it from COPD to arthritis, or change it from any condition that does not have normally a generic drug. The generic drugs tend to be for maintenance. Keep my blood pressure low, keep my cholesterol low. But when you get to a point you've tipped over, it's created the circumstance that you now have a chronic condition that's affecting some part of your body, or multiple organs or multiple systems in your body. Now you're no longer just trying to maintain health, you're trying to recover it. And the cost of recovering that, maybe there's a message built into it, don't let yourself get there in the first place. But hey, you know what? This is the great thing about our modern medical technology and pharmaceutical miracles. They forgive all the sins we've committed in our youths and not so youth. But once that happens, and we start asking, is this Advantage plan going to be good enough to cover my drugs? And we're constantly looking then for Advantage plans that have built-in drug coverage that's effective, and we find there's limitations for that. We're finding we can't step out and get the higher level of coverage with a standalone Part D that may exist, and you just accept what you get, and there's not much you can do about it. And what we're finding is, not just for that, but for the high-end services, not just the drugs, but the procedures, the diagnostic and intervention procedures. Like if you're diagnosed with cancer and you're going in for in-office or inpatient chemo, the cost, or as much as 20% of the cost of those drugs. Now we're not talking hundreds, we're not even talking thousands, we could be talking tens of thousands of dollars per month. And suddenly we ask ourselves, oh wow. And now, forget about getting a Medigap, you'll never pass through underwriting, and it's like the best you're hoping for. Is there some Advantage plan that's going to help me access these drugs? Or is there a access program from the manufacturer that's going to help me access those drugs? And that's not a guarantee. That's a benefit on their part that they can give or not give at their whim, or say, we've given enough this year, time out, see us next year. And so I would say anything that represents a chronic condition, Sue, anything that represents an escalation of basic, typical healthcare circumstances is likely going to compel a drug that is not recognized as generic, that's recognized as either a preferred brand or a non-preferred. Preferred, maybe $40, $50 of cost sharing. It's the ones that the Part D plans wish you would take and persuade you or compel you to take by keeping the cost sharing, in the 40s and 50s, versus the drugs they're saying, we wish you wouldn't take them. If you do, it's going to cost you a lot. And even if you're willing to pony up that money, no, I need this insulin. I need Humira. They may very well say, well, too bad. There's another drug that we would rather you take that's cheaper, but it's not as good as. It doesn't work. This version of insulin isn't as good as the insulin I want. Well, tough. So either you demonstrate to us through what's called step therapy, or through your doctor intervening and appealing that you get this drug, or you don't get the drug. Even if it's on your formulary, even if you're prepared to pay that cost, there's still no guarantee you get it. And to be able to reach out to another plan, to another company, it's like, no, that's your Advantage plan, that's your drug coverage, live with it, or not.
So, there are a couple of take-homes, again, for those of you here that it's relevant to. If you have a Medicare Advantage plan, then probably by now your company has sent to you, this is what our plan will look like for 2020. If you haven't, you'll be getting it very soon because they have to notify you by October 15th. They'll tell you if there's a change in the premium. They'll tell you what new services they might be offering. And then, yes, truthfully, it takes some time on your part. You need to look through the fine print. But any changes they made to services that you've used in the past, they will so indicate. So they'll tell you what's new, the new premium charge. They also will tell you, trust me, it's cumbersome to go through, I know, but they will also tell you, hey, if you want, you request it if they don't send it, here's our new formulary. So you could go through and you can look and see, which drugs are. Now, of course, on the Advantage plan side, again, if you're happy, is the adage goes, if it's not broken, don't break it.
I thought you were going to say if you're
But on the
happy
other
and you
hand-
know it, clap your hands.
I didn't choose that one. But seriously, it gives you the opportunity to compare Advantage plans. Again, for whatever reason, you chose the plan, you like some of the perks, you know hypothetically what services you're using now. If it happened that during this past year, whatever it may be, there was some new service that you had to access, or you realized, as Bill made reference to, maybe you had a visit to the emergency room that didn't turn out to be an admission, or it was a 23-hour observation. These are outpatient charges, et cetera, et cetera. So you can compare Advantage plans. Conversely, if you had a Medigap, or if you're relatively healthy and you want to, if you will, test the water. I mean, if you don't have any pre-existing conditions, though you may be, a year older than when you entered Medicare at 65, I don't know your ages, I'm not making any supposition, but seriously. So then theoretically, during open enrollment, yes, you could look to see what would be the price of a Medigap, understanding that depending on which level of Medigap, again, now Medicare is primary. As Bill said, either way you pay your, quote, membership dues. But the part that a lot of people don't realize is in the Advantage plan scenario, basically, you pay your dues to Medicare. Medicare pays what's called a capitation fee to the company you chose. You don't have secondary insurance. Your insurer is, I think you said in this case, Highmark. So Highmark is, it offers everything that Medicare A and B does, plus more. Yes, we refer to it as C and D, but understand it's not a supplement to C and D. It's your insurer. It defines the network, it defines the drug plan, etc. And the expectation is that you have co-pays, and the more services you use, not prescriptions for the moment, the more services you use of either getting admitted to the hospital or outpatient services, you pay co-pays up to the out-of-pocket max. Okay? And you have a question. And I apologize, I don't remember your first name.
Don't worry about that. There's other-
Okay, my name is Steve.
I'm being intrigued by the comment about Part D and prescription medication. We don't live in Buffalo. Canada's not a stone's throw away. But I can get in a car, be in Canada in 5.5, 6 hours.
Agree.
Is there any advantage of, instead of going to Giant Eagle here, taking my prescription and going across the border?
Well, it's a little complicated answer. First, I don't know that they will accept your prescription in Canada. Speaking as a physician, hypothetically, I'm licensed in Pennsylvania. Previously, I was licensed in New Jersey, and if I write a prescription here in Pennsylvania and my patient goes to California, since I don't have a license to be a provider in California, and again, if I were a provider in your network, in your Advantage plan, when they go to California, they're out of network. So there are some people that look, look to buy medications from India or Canada and so forth. It won't be covered by your insurance. What I don't know is whether or not in Canada they'll recognize the prescription that your provider wrote.
So in Montreal or in Quebec,
Back over one little detail.
I'm sorry?
To go over one little detail, you're licensed in Pennsylvania.
Correct.
You write a prescription for me for say, an antibiotic.
Correct.
I go to California to a pharmacy.
They will,
accept it?
they will not take that prescription.
So then I would have to have it filled here and take the medication.
That would be the assumption, yes.
Hopefully they're not going to stop on the aircraft.
No, but the point is, for example, what happens nowadays in most cases, whether you have an Advantage plan or a Part D plan, they have preferred pharmacies. So you tell me as the provider, hypothetically, I'm going to go to, I use Rite Aid. I'm not showing preference, I'm just giving examples. Rite Aid, Walgreens, CVS, etc. Okay? And basically, there is, as far as I know, Rite Aid, CVS, Walgreens in each of the 50 states. So electronically, so I wrote the prescription here. You're in the system, your prescription is registered in Pennsylvania where I wrote the prescription. Yes, they will honor that in the Rite Aid in California if they know, they look you up in the computer. Oh, as I said, apologize, I don't know your name. Yes, Mr. Jones, yes, I see you're registered here. Yes, we'll grant you the prescription. What I'm saying is if you walk in, they don't know you, they don't know me, and you walk into a pharmacy in another state, they say, I'm sorry, this is written by a provider that is not licensed in our state. I do not, no physician that I know has a national license. I have a national narcotic license, but again, they would only honor, by law, but they would only honor the narcotic prescription in the state where it was written.
And if you're going way beyond that into another country, their rules may be absolutely restrictive that any physician from the United States that wrote this would not be honored at any of the pharmacies in Quebec or Montreal or Ottawa or anywhere else. And simply saying, oh, okay, I'm going to go to Canada, I'm going to drive up 5.5 hours, you may get there, go into a pharmacy and say, here, and the pharmacist will say, you know, you got to get a Canadian doctor, preferably one in this region, to write this script out, or you're not going to get your drug filled here.
Now, I will share with you, in all honesty, I mean, you know, you raised something interesting that we discussed earlier today in another audience, much larger turnout. If you, how can I say it, if you read the fine lines, it's very clear that if you look for a coupon for a drug, or there are certain benefit programs like GoodRx, it says not to be used in conjunction with Medicare. It's a true statement and there's no change to that. However, pharmacies in our area, at least, and now I'm not promoting them, but I happen to know of their practice, specifically Giant Eagle. If Giant Eagle, if you happen to be, you're prescribed a new drug, it's during the benefit year, gee, I'm really sorry. You know, we ran this through the insurance company and your copay is going to be $450. Oh my God. Wow. Isn't there anything else we can do? What Giant Eagle is doing now is they're basically counseling the individuals. Again, be the educated consumer. But they're saying, sir, you know, your insurance company is either denying it or charging a very high copay. Let me tell you of a discount program called GoodRx, or you could look online for your medication that they told you the insurance company would charge a price so high. So in other words, instead of running it through the insurance company, okay, and the same thing, there's the drug, great, there's a generic, wonderful, GoodRx, this would be your copay. It's not going to be for free, it won't be zero, especially if it's that higher tier drug, but you may actually save money that way. Now again, I've been told by patients that they get medications, again, I'll speak of an actual example, for reasons that are unclear to me, but it is what it is, okay? The popular drugs used by older men, specifically Viagra and Cialis, are very expensive, higher tier drugs by Medicare. Why? I can't explain it. Similarly, there are some estrogen preparations that are administered by cream that are very expensive by Medicare. So at any rate, having said that, there's a patient of mine who gets his medication, a generic equivalent of one of those two medications, from India and saves a lot of money. Now, the caveat that you need to be aware of is this. Again, think about it. Remember, you have an Advantage plan, and Highmark, if that's the company, provides you coverage. If you happen to have an allergic reaction to a drug that was not authorized by them, or in other words, didn't run through their company, and that's discovered, they may deny coverage for the treatment for the side effect of the allergic reaction you had. I'm aware of such situations.
I have to say though, Highmark
Okay.
medication.
About, what about medication?
Yeah.
Good.
Medication. I mean, they went through, they reviewed, and I don't really take much.
Mhm.
You know, they called and checked with me. And the one medication that I did say was, you know, I thought was expensive, and it's really, you know, it's not.
So,
It's
but
nothing
because,
like showering or anything.
no, I understand, but
Yeah.
because it's a higher tier?
Yeah.
An estrogen drug,
They were
okay.
perfectly willing to work with me and reduce the cost, and
One-
give me another alternative,
Well, no, give you an alternative,
which
and then,
was a surprise.
give you.
Well,
an
no, don't be
alternative that
surprised at the alternative. It's beneficial to them.
Yeah.
I mean, they're going to say, oh, you got to pay $200 in copayment, but that probably means they're paying $800 in their share of the copayment. If they can get you to take a less expensive drug that's only $100 total, hey, you only have to pay $20, and we only have to pay $80. It's a win-win for you and them.
And, right, and they're keeping you as a beneficiary. No, so I'm glad to hear that, but that's what I referred to before.
I was surprised. It was just a phone call out of the blue, like, hey, I'm the Highmark pharmacist.
We
Would you like
noticed
to-
you're costing us a lot of money here. Shall we offer you an alternative that'll make you happy and us happy?
Okay. But anyway, you know what?
But your
We
bel-
just go house hunting when we go to Canada, so that's.
Well, I was going to say, your beloved has got this itch that needs to be scratched up in Ontario. Ah,
Well,
okay.
what's that?
And again, you know, it's like one of the reasons that people think seriously about locating outside this country is because of the cost of health care. And they're finding that they can access medications, they can access healthcare services by becoming an expat in a place where the healthcare system is more regulated, more guaranteed that the costs are going to be controlled, and this becomes a significant reason to go. But keep in mind, in a different location, even within the United States, certainly an escalated possibility outside the United States. You're playing by that country's rules in terms of how you access care, how you access meds. And there's this presumption and almost a myth that, you know, we make this pilgrimage up to Canada. Do, but keep in mind, and think of it this way. If I go to a big box pharmacy here, and now I go to California to the same big box pharmacy, and it's possible that pharmacy in California reaches out to that pharmacy in Pennsylvania and says, how did we secure this drug in Pennsylvania? Because we have presence in both states, there is the possibility that we can leverage that presence with that presence. Maybe there's the same kind of presence in Canada and Pennsylvania, maybe not. And again, the further we go outside the strictures of our own national system, we're now at the mercy of them saying, here's how you do it. Now, there's nothing necessarily wrong with you saying, okay, if this is the game I have to play, I'm going to work with a doctor who can create a prescription that lets me go up and get it. And maybe in certain cases, in these other places, they're not even requiring a prescription. Holy moly. There's some other countries that it's like the only prescription you need is a Washington, a Jefferson, and a Lincoln, and it's like, there you go. But now the concern is, if they're that freewheeling with giving me that drug, it's like, is this really that drug? Oh, Lord, I'm growing hair where I shouldn't be growing. I don't know what happened here.
I'll raise something else if relevant. I don't know. Just say yes or no because I can't see what it says on your hat. Are you a veteran?
Yes,
Have you used the veteran health care system?
no, I don't qualify.
Or you don't qualify for care? Or
I'm in a category that I don't qualify yet, I'll put it that way,
okay,
yes.
okay.
Now, there's a reason Steve has a certain gravitas when he... Go ahead.
No,
Tell me
but-
your curriculum vitae.
Well, okay. There's a reason why I asked that question, and we'll go back to that. And I didn't fully understand your answer. So in my former life, as I think Bill jokingly alluded to, if not here earlier, I'm semi-retired. In some ways, I think I'm busier than I was before, but joking aside. So I had been in full-time academic practice. I'm a gastroenterologist. I was hired by the University of Pittsburgh back in the mid-1980s, and at that point in time, I had 3 employers. There was, before UPMC, there actually was something before UPMC, but joking aside, I was employed full-time by the University of Pittsburgh Medical School. I had a part-time appointment at then what was called Presbyterian University Hospital, and I had, in government terms, a 6/8 appointment at the VA. Over time, I had increasing responsibilities on the teaching side, and I was on the admissions committee of the medical school. I continued to have a practice at what soon became UPMC, but frankly, with no political comment meant, UPMC wanted more of me than the federal government would allow. I had obtained federal funding for colon cancer research. I also gained responsibilities to be the director of clinical services of gastroenterology at the VA. So in 2003, I had to divest myself from that place called UPMC. It wasn't a big loss financially. I was full-time at that University Drive VA, doing the full gamut of endoscopic procedures, going in for emergencies, et cetera, et cetera. And then in 2013, I retired from full-time practice. I continued to teach both at the medical school, at the School of Pharmacy. I'm based at the Birmingham Clinic on the south side, and I've been doing healthcare navigation and healthcare advocacy since 2013 with the gentleman to my right.
And I am working
So
him
the
harder
reason why I
than he
asked-
ever had to work at the VA.
And the reason why I asked him about the VA, and I didn't fully know what you meant by, of course, I'm well aware of certain priority classes and means testing and so forth, but, certainly if you were eligible with, an honorary discharge at the time of your discharge from the service, et cetera, and if you register, then you could certainly make yourself available of things like the audiology service there, the eye services there, the dental services there, if you qualify, I agree. And then theoretically, again, if you qualify, you could have concurrent care, meaning that as long as you're seen by a VA physician, whether it's at their main facility in Oakland or one of what are called the CBOCs, the community-based outpatient clinics, as long as you're seen once a year, outpatient records from your PCP privately presented to the VA similarly communicating with your outpatient private doctor, because there are different electronic systems, then your prescriptions could be filled at the VA, potentially at a lower copay than you'd pay through an Advantage plan. That's why I asked about that.
Thank you for the information, because I said, I went through the process, I don't qualify yet, I'm too healthy, I'll put it that way.
I understand. That's good. Don't misunderstand. But
There's a group I'm associated with, and the part is, these guys are hurting. 60% disability, 80%
Correct.
disability, 90% disability. They have shrapnel on their back and their legs, and these guys are hurting. Fortunately, I'm not in that category yet.
good, and I don't want you to be, but if you are registered there and if you're seen by a primary care provider, then theoretically, again, if this is a benefit for you, now, again, I'm not selling anything, don't misunderstand, but, example, they have a free audiology service. Hearing aids are never covered by Medicare. You'll have somewhat of a benefit through an Advantage plan, meaning a credit towards maybe a $3,000 pair of hearing aids. If you're evaluated, again, if you're registered at the VA, et cetera, if you're evaluated free of charge by audiology, and if this is applicable, and they say, sir, I think you need hearing aids, it'll be provided free of charge. Again, the eye clinic there, they do an examination and so forth. Of course, there's a limitation to certain types of frames and lenses that they have available, but again, free of charge. Dental is not so, I'm not speaking negatively, I don't mean that, but because of, frankly, the overwhelming potential dental needs for older individuals, crowns, bridges, even dentures, etc., dental nowadays is very hard to get into at the VA unless you have a service-connected disability and or hypothetically, not that I'm wishing this to happen, but hypothetically you have a medical condition and you're becoming malnourished or you're having bad oral cavity issues. Again, if so certified by the medical side, then the dental clinic would provide service, again, free of charge. But that's fair. That's yes, it's a benefit, but you'll probably never get in.
And the thing that Steve didn't even mention is if you are eligible, if you meet the criteria, most individuals that can access through the VA their prescription meds tend to rely exclusively on that as their avenue for accessing their meds at a considerable discount
Right.
than what they would be getting through the Part D system, through any other methodology. Now, the VA has a limit of their formulary, but honestly, most of the drugs that are most likely going to be utilized for most conditions are going to be accessible. And this often is where individuals hold dearly onto the utilization of the VA, not because they have this love affair for the VA system, but because by being seen through a VA physician and prescribed the drug through a VA system, they now have access to those drugs they could never have imagined getting in any other form for that low cost. And this is one of the inherent values about being able to leverage that system over anything else.
And again, related to that, so the VA has, frankly, it came into effect even before some of the newer electronic systems that Allegheny General or UPMC are using. The VA has an electronic medical record. Again, if you're registered at the VA, so you're registered, they have you in their computer system. I can't any longer, but when I was on staff at University Drive, Pittsburgh, and again, in my area, one of the things that we serviced a lot of patients, either that were pre-transplant evaluation referred in from all over the United States and or post-transplant and having a problem, I could access the medical profile, the entire history, and importantly, the drug profile from anywhere from 174 VA hospitals, be it in California, Puerto Rico, Michigan, Idaho, Pennsylvania, and so forth. So it goes back to that system of, although I wrote the prescription as a VA provider, in that case, full-time government, but at any rate, as a VA provider in Pennsylvania, and my patient happened to be in Los Angeles, California, the pharmacist could pull up the profile, et cetera, et cetera. They actually called at one point to make sure that the record was, this was the dose of the anti-rejection drug, et cetera, and very easily filled over there.
Yes?
Sue.
So, I met someone who said their father was on an HMO or like an advanced smoker and he had a stroke in Arizona. And so then they stabilized him and shipped him back to Pittsburgh. So maybe you could talk a little bit about, when you travel, if you have any.
It's called emergency care. So, now, let's say you have an HMO, not a PPO. Health Maintenance Organization has a very restrictive network. Doctors, hospitals, typically in a limited region. Now, they may have courtesy. Highmark often says, hey, certain hospitals, certain doctors, certain locations, you have courtesy as long as they're within that regional Highmark system. But preclude that and just say, I have a very, very limited HMO capability. Now, I'm in Pittsburgh, and all my doctors and hospitals are based in the Pittsburgh area, and I'm okay with that. But now I'm making a trip. I'm going to go see the kids out in Denver. Well, along the line in Keokuk, Iowa, I just like to say Keokuk, I'm getting chest pains on the train. I'm on the train because I don't like to fly, and it's easier to get off the train than an airplane. So I'm having my chest pains, and I say, oh. Now, it could be an infarction or it could be just a fart, but I'm not sure. Nor am I compelled to be the expert that knows this. As long as there is a reasonable presumption that I have a condition which could be deadly or significantly impair my health, I have the expectation, while I'm outside, it could be travel most likely, but could it be any reason, I now have the ability to go to the Keokuk General Hospital and say, I'm having a situation. Now, my recommendation would be don't underplay. Well, I'm not sure, and it might not be anything. No, I'm having, I think, a heart attack. Write it down. I am having an emergency. Write that down. Just write it. Emergency. There you go. Once it's determined to be an emergency, an unforeseeable event that could have dire consequences, Keokuk General, for that purpose, is in my network. It's remember the Sharpie that suddenly it's in Alabama? Well, that's the thing. Suddenly that network, I got me a Sharpie and I drew it all the way over to Keokuk, Iowa and back. See, that's my network now. For that event, for while I'm there, until they stabilize me so it's not an event, and now out you go. Now, what the hospital's going to do is call Highmark, we'll make it Highmark, and they say, hey, emergency. Hey, we're in your network for this. We get paid the same. Now, that doesn't mean it's free. That means you're going to be treated as though you were in a hospital within the network, wherever, and your co-payments, your whatever is going to be. The hospital will take you with the expectation. Highmark will accept it. Now, they could try to challenge it's not really an emergency. This is why you want to really stack the deck in favor of defining it as an emergency. And also, just a recommendation, go to a hospital. Go to a full-blown establishment as opposed to checking out with, Dr. Wassel and his pig farm. It's like, you know what? I want all of the power of a institution pushing that this is an emergency to get reimbursed and having a viable operation with my insurance company, as opposed to a small practice saying, we're going to try. Now, theoretically, you could go to any doctor that has a reasonable accessibility. Hospitals, large clinics tend to have more capacity, and plus they understand. And if you're showing up there not just, well, I should get checked, but I'm seriously worried, this opens the door. And this is where when a person says, oh, I better get a PPO so I can travel. PPO, Preferred Provider Organization, which gives you the ability, unlike the HMO, to go outside the network, but you're going to be paying probably 30-ish% or more on the cost for those services. Even with an HMO, if, I'm going to get my PPO because I'm going to travel, HMO will work just as well. What is it you're worried? Well, what if I have like an event while I'm traveling, while I'm visiting the kids? So you don't plan on actually going to doctors just regularly while you're in Denver. No. I'm just worried if I have an emergency. If it's an emergency, your HMO will work just as well to tide you over. And that extra 30 or 40 or 80 or whatever dollars you're paying to have the PPO capacity, there better be some other reason that PPO is giving you something more than. If it's just that, save your money every month and do it with the HMO product. Steve?
Okay, Sue, so going back to your specific question, I don't know enough of the situation you may or may not know. So let's say for the moment from what you said, as Bill was presenting, I think you said in whatever state it was in, Arizona. So if the person had a stroke, it was a true emergency and they were admitted. So now that HMO is going to work the way it would work if they were admitted to a hospital with an in-network. What I'm saying is, a hospital in Arizona says, excuse me, this patient's not stable for transfer. He is having a stroke. We will treat him here. And then under that HMO, hypothetically, there's either a per admission hospitalization charge or a per day for the first 5 or 6 days. That's what they'll be subject to. Here's the problem that presents, depending on insurance companies. Understand that, yes, more and more, some Highmark advertises this, they talk about snowbird coverage. So if you have established with them, they might have snowbird coverage in Florida or Arizona. That aside, once the person is discharged from the hospital says he's stable, now we have a problem. We have a person who's stable, doesn't need an acute care facility, but maybe he can't get on the plane to travel back to Pittsburgh. Maybe he needs to go to a rehab facility. Oh, now we have a problem. What is the rehab facility? Is this going to be considered by the insurance company in network?
Part of the emergency, part of the continuum of care that started based on the emergency.
Okay.
Maybe it will, maybe it won't.
Correct. Up to the, again, we're not speaking Medicare, we're speaking of an Advantage plan, so it's up to Advantra or Highmark or whoever it may be. Okay. Now the person's stable for transfer and is going to come back to Pittsburgh, home base. Okay, well now, there may be an outline of, hypothetically, he needs rehab services. He needs to see a neurologist. He needs to see his PCP. These will be at outpatient services, of course, only within the defined network. In other words, the emergency has been treated, stabilized, within the defined network. And now, although maybe not anticipated, but now there will be copays of whatever those services are. You know, to underline something that Bill said, I don't know if this is relevant to you. The fallacy of a PPO, for the reason that Bill mentioned, when you read the small print, and patients often don't, let's go back to one basic part at the beginning. If you only had Medicare A and B, in other words, if you said, you know what, I don't want an Advantage plan because I want to have freedom of Medicare, I'm going to get a Part D because I need to have that. So if you only had Medicare A and B, you'd be on the hook for the deductible of Medicare A, meaning when you're admitted to the hospital. It's a big chunk, but it's a one-time charge
It's about $1,400.
per admission. Okay, it's a big chunk. In 2019, $1,364 to be exact. And that deductible would be every 60 days or sooner. In other words, each 60 days, you're admitted to the hospital again, another deductible. Or if within the 60 days you have the bad luck of being admitted for different diagnoses, in other words, it's not a condition, it's not related to the first condition, second deductible. But hey, most likely you won't get admitted to the hospital. So if you only had A and B, okay, comprehensive hospitalization minus the deductible, and Medicare B, what you pay for, covers 80% of all outpatient services except prescriptions. So you're on the hook for 20. And the point that Bill mentioned was if you have a PPO and you're allowed out-of-network coverage, go figure. Out-of-network coverage, you're on the hook, depending on the company, for either 30% or 40%. Hey, well, I don't want to use my Highmark card PPO. I'm going to use my Medicare card. No, you can't. You signed up for a PPO. So in some cases, people are paying, it is what it is. Bill asks pointed questions sometimes, but we asked
Sometimes.
an insurance, there's an inside joke, but seriously, we asked an insurance broker from a particular company, which I will not name, why do you sell these higher priced products?
As
In
in
some
HMOs and
companies-
PPOs.
And no, higher priced PPO specifically is what I'm referring to. As in some companies, they get a catchy name like Gold or Deluxe of some kind. Trust me, those PPOs are more than $200 a month, knowing that there's still a co-share from the patient that they'll pay, a higher percentage of copay paid on the out-of-network PPO. And the answer was, we sell them because people buy them.
We have looked every year at the basis by which you could economically benefit from paying a $200 or $300+ monthly premium for those services. And we've concocted all the parameters we could think of, and here's what we've come up with. By the time you have incurred enough copayments and deductibles with that zero premium HMO or the $20 or $30 HMO, that $300 PPO would have said, ooh, we're not going to charge you nearly as much. We're going to save you all this money. By the time you have paid out that more escalated cost by having the zero, you're going to hit something called that plan's out-of-pocket max. Now, every HMO and PPO has an out-of-pocket max. Every plan has some amount that when you've hit that amount, for the rest of that calendar year, the plan year, you're off the hook for any copayments or deductibles. You still have to pay the premiums, and you'll still have to pay the cost sharing for your drugs. But just in terms of medical care, inpatient, outpatient, I've met my $6,700 out-of-pocket max, or for plans that have a $3,400 out-of-pocket max, and there are some, I've met my $3,400. I've met it with my zero premium HMO, where, oops, I've now run up a bill of $3,400. And the end, for the rest of that year, done. For your co-payments and deductibles, that's the insurance company's responsibility. Now, if you hit that out-of-pocket max with the $300 PPO, they're still going to say, where's my $300? Where's my premium every month? And so and I'll use $300 because it's easy arithmetic, for $3,600 a year, I have an expectation, wow, I don't have to pay nearly as much in co-payment and deductible as with that zero. Except I will likely, with my zero premium HMO, hit my out-of-pocket max, and especially if I have one that's on the lower end, and it's like done. I've spent $3,400. That's the worst that could happen, $3,400. What's the worst that could happen there? $3,600 just in premiums. And there's the premise. You know, to effectuate that thing, I've got to have such extremity, but not too much, because then I'd hit the out-of-pocket max, and I've got to be thinking about, oh, well, what else can I get? What else can I get? What else is there that's worth outlaying that premium? And if you're thinking about it, go all the way back to the beginning of this conversation. If you're going to spend $300, why the hell didn't you get a Medigap in the first place? Because no one told me. Because this guy just came back and said, oh man, did I make a sale. All right, I'm going down to Florida. I'm done for the year.
No, I mean, I agree with what Bill said, but the issue is when we do one-on-one counseling, part of what we need to look at, and sincerely, apart from needs as far as use of the healthcare system, et cetera, everyone has different priorities. And no joke is meant, though again, we try to weigh and measure what the cost would be. There are some people that say, well, I want to choose an Advantage plan because of some of the perks that I get. So again, things like the free gym membership, whatever the name may be, Silver Sneakers, Silver Fit, whatever, the free gym membership, okay, calculate what the cost of that is, but to some people that's a priority. I want a credit towards hearing aids. So Medicare primary and Medigap, Medicare will never, never, never cover hearing aids. Okay, maybe you won't never need them. And again, the credit is probably maximum around $900 some for a $3,000 pair of hearing aids, but to some people it's a perk. The newer changes for next year, a little bit of vision and dental care. Well, understand what it means. It's not dental insurance. And similarly, as far as vision is concerned, if you have a medical diagnosis, no, it doesn't count when the arms get a little shorter, but seriously, if you have cataracts or glaucoma or macular degeneration or conjunctivitis, then so there's a medical diagnosis, of course, then with your Advantage plan, you're seeing a specialist, okay, here's the copay. So the perk of routine vision, okay, maybe some companies will give you a small credit towards a pair of eyeglasses, etc. So that, you know, it's a weigh and measure.
There's also another factor, and you know, honestly, we underplay it because Steve and I have reached a point where we feel pretty confident that we understand how to navigate through the system. But I have to force myself regularly to put myself in the place of a person who is lost, who is just overwhelmed, not just in the picking of the product, but also the using of the product, and trying to figure out what that ANOC letter and what that bill statement looks like, and how to make a choice, and how to make an enrollment, and what to do to get, you know, into the hospital, and they want someone to navigate them. And they are inclined to see a value when I say to you, if you join my HMO or PPO, I will assign to you a navigator or a concierge. And that person you call 24/7. Well, you know, less the 3 in the morning, but you can access that person, and that person will explain what's going on, help you work through, work within the systems, hospitals and doctors and care providers, and smooth things over. Now you have to decide something. Is that person's value based on your true belief that they are there for you? They are your navigator, your concierge, that's helping you make the right decisions and navigate through the system, or are they assigned to you by the insurance company who is compelling you to move in the direction they want, and they're just kind of pushing you in that and giving you suggestions that are really beneficial to the insurance. Now, you want to think it's beneficial to the insurance and you. You want to think that anything you're going to do with this insurance or with this healthcare system is mutually beneficial to the care provider, saying we're doing this in the most efficient, cost-effective way, and it's giving you the best quality of service. But you have to believe that. If you believe truly there is that sweet merger of those two, and the navigator is simply the marriage broker of this sweet relationship, it's okay, be happy. But if you're given more to a skepticism of, why is this insurance company in business? Why has it created an integrated network? Why does this insurance company own care provider systems? Why does this care provider network suddenly own an insurance company? Why is it? Is it about the love and the altruism for the community? Well, last summer kind of demonstrated, a challenge to that. Or is it about maximizing the amount of profit? And if we use this model, what's the model? I get whatever I collect in premium. Now, if it's a Medigap, that's my amount. But if it's an HMO or PPO, I get that amount and then some, another 1,000, another something. What I make ultimately in my profit is the difference between what I've got in premium, what I've got in subsidy, and what I had to outlay from that capitated amount to pay for this guy's care. The less care this guy uses, the less cost it imposes on us, the more of that money I get to keep. Thus, I am motivated to keep you using as little as possible. We want to believe this minimal utilization is because they truly believe we don't need it, not they truly believe we need a bigger, better bottom line for the shareholders. This is where you've got to decide. There is no right answer. It is where you are inclined to believe and put your faith in a system. That the system that relies on for-profit, free enterprise, driven by how do we most cost-effectively deliver a service that is of quality and that people embrace, and they'll come to us over and over and over if we can do this. Versus there is an altruism, hopefully, you don't have to believe it, that is driven by a sentiment that we do this not to make a profit, we do this because it needs to be done. And it needs to be done in a way that hopefully is the most efficient and cost effective. That doesn't mean government per se, but we balance these two values. And we ask, who is the more likely provider? But keep in mind, keep always this in mind, that the system, this integrated healthcare system that is both a private insurance and, they'll call themselves nonprofit, but healthcare system, spends more money on marketing than the Medicare system spends in 10 years. I'm being hyperbolic. I don't know how much they really spend, but certainly a significant part of the budget by private entities is to encourage you to believe they're the best. We're the best. No, we're the best. It's like, okay, best is a superlative. Who's the best? I'll put you all in a room in your underwear, you fight it out, whoever comes back out, I guess you won. But this is what we're looking at. And when that happens in the worst case scenario, and you've got two monoliths about to square off in their BVDs, the real casualty is the beneficiary, the community, that said, while you guys are empire building and trying to knock each other off, we can't access this hospital or that doctor or this care, and we have such uncertainty that people left both of these seeking some alternative that would give them a better guarantee of accessibility. Never before, and I've been doing this for almost 2 decades, have I seen such an imperative about accessibility. It was always about cost. You know, what's the most cost effective? Because we had gotten used to pretty much with either company, we could access the facilities. Last year was about, I need to see this and this, and what is going to deliver the this and this. And if it means not getting the most cost effective, if it means having access. And there's two, I really don't care who my doctor is. Okay. But I found out very more likely I care about who my doctor is. My doctor saved my life. The Hillman Center saved my life. I want that so badly. That, I'll do what it takes to have that in cost and in sacrifice. And that to me became the point that drove. The most imperative thing, I think, is guaranteed accessibility. Guaranteed accessibility says where you want to go is where you get to go. The doctors you want, the hospitals you want. We should, my belief, create a system whereby whomever you select in this entire wide country can treat you and expect to be compensated. And the system we should be striving for is that kind of system that does not preclude, for whatever reason, that offers that possibility. Now, right now, there's only one game in town that can do that. You don't have to love it, you don't have to buy it, but at least a characteristic is that. And this has compelled me, last year has been a big deal in motivating me to see this as a factor. It's not price. Oh, God knows it's price when it comes down to accessing certain services and drugs, but I've developed a true loyalty to a person that I believe has saved my life. Now, whether it's true or not, it's that emotional bond. It's that thing which compels the continuation of their care and the belief that that care is what is allowing them to stay alive. And I don't want to break that up. And I don't want to tell that person you have to give this up to have that or give that up to have this. And that's what drives me to get really radical about this. That's a big deal to me. Accessibility. All right, I'm done. I'll have the soapbox. Welcome.
Thank you.